I hope you're feeling refreshed after that wonderful meditation with Dr. Johnson, and that you're ready for our next panel focused on cognitive changes. Cognition is the act of mental processing. There are many aspects of cognition: thinking, understanding, learning, remembering, problem solving, language, and more. But most of you are already very familiar with cognitive changes. You reported it as the most challenging symptom for you as care partners. Over half of you put cognitive changes in your top 3 symptoms, so I'm thrilled that we've got such a great group queued up to discuss this topic. The panel will be moderated by Jill McClure, who has been answering the Parkinson's Foundation Helpline since 2012. She shares that working on the Helpline has been a terrific fit for her because she thrives on connecting with people, and it has been especially meaningful for her since her father also lived with Parkinson's disease. She's joined by Amanda Janicke, licensed clinical social worker and certified dementia practitioner, who also serves as a Parkinson's disease information specialist on our Helpline. Her career has focused on supporting and advocating for older adults, people with dementia, and individuals living with chronic health conditions, as well as their families and care partners. Our final panelist is Adriana Strutt. She is a board-certified neuropsychologist and associate professor of neurology, psychiatry, and behavioral sciences at the Baylor College of Medicine. She's also the founding director of BCM Cerebro, a Spanish outpatient clinic, the Spanish Cross-Cultural Fellowship, and Taquitos de Sesos, an international online didactic program at Baylor College of Medicine. She is a lifespan clinician, clinical researcher, and international educator. So with that, I will turn it over to Jill.
Hi, thank you, Annie. We're so pleased to have the opportunity to speak about cognition today. And we have some wonderful questions. We'll do our very best to try to answer them all. The first group seem well suited to our neuropsychologist, Adriana. So we'll start by asking Adriana to help us with Mary from Washington. She's wondering about how quickly cognitive changes might begin and occur over time for somebody who's having some memory changes, but really doing well overall.
Sure. So when I looked at that question, the question I think also included some instances of confusion. Dear Mary, if there are instances of confusion, I would say that just given my clinical experience, there are probably been more cognitive declines or subtle declines than you might be able to see in day-to-day functioning. It also depends on how you're defining confusion. Are we talking about being disoriented, maybe being unsure as to how to sequence a task if somebody's working on something, or confusion meaning that they're not sure where they are, how they got there? So I think we have to be careful with how we define confusion, and also to know that it can be very difficult for individuals that see their loved one with Parkinson's on a daily basis to identify subtle cognitive declines. And I think part of that will depend on what your structure is in your daily activity. If you have a simple routine, maybe you're both retired, you have a set schedule of activities that you engage in, then it might be harder to identify some of that cognitive decline, because then you're counting on your loved one to use rote memory and procedural memory to get them through the day. So my recommendation, I guess, is a little biased as a neuropsychologist, to say that it would be, I think, best to have your loved one go in for a cognitive assessment. If you go in for neuropsychological testing, then the neuropsychologist can identify the cognitive areas of strength and weakness and give you tailored recommendations as to how to help your patient with Parkinson's and to maybe structure their day-to-day activity, or how to become more aware of some of the difficulties that they might be experiencing that you might not be able to catch all the time.
That's great. Thank you, Adriana. I'm so glad you also shared with us a little bit about sort of what cognitive testing can include and the kind of help it can suggest and promote in daily life. The next question is from Mary in Arizona. She's wondering, how do you determine whether somebody has cognitive changes, cognitive difficulties, or actual dementia?
Sure. So there are two common terms, mild cognitive impairment, which is sort of the old term. That now has been replaced with mild neurocognitive disorder, but both are used frequently in the medical field. And then you have what is known as dementia or major neurocognitive disorder. So what happens with Parkinson's disease is that it's a disease that progresses over time, and cognition is one of the most, or declines in cognition are one of the most common non-motor symptoms that are seen in Parkinson's disease. So when you're having cognitive declines, they can be declines in memory and working memory, being able to manipulate things in your head, attention, language. It can vary depending on the patient. If those declines do not impact the individual's ability to function and complete what are known as activities of daily living, such as being able to take care of yourself and your household, manage medications, your finances, then those declines fall under the category of mild neurocognitive disorder or mild cognitive impairment, secondary to Parkinson's. If the declines are a little bit, more noticeable, and there are declines in functional status, then you meet criteria for a dementia. So I think it's important to know that sometimes, like we've answered in Mary's question, there can be some subtle declines, but your day-to-day functioning is still not impacted. And so at that level, you would be, those declines would be considered to be mild neurocognitive disorder.
Okay, great. And so related to the changes that occur, Amanda in Colorado asks, how can you help somebody who has cognitive changes and limitations adjust to those changes, particularly when they have memory problems that sort of help them or hinder them in remembering, these are the limitations now?
Sure. I think the most important thing is to make sure that we're keeping our patient, our loved one with Parkinson's disease, busy during the day, feeling useful, increasing their level of confidence, trying to give them a good quality of life. I think, when we talk about cognition, we have to see the individual as a whole and realize how their day-to-day functioning or engagement with others is also very important. Some of the things that we do as neuropsychologists are, after we do our assessment of people's cognitive functioning, we tailor recommendations to help them with day-to-day activities. So I think that if you can engage your loved one with things around the house, with tasks, even with mental stimulation that will help them feel confident and can use the abilities that they have, I think that's very important. You also want to give them some challenging tasks to sort of do, the brain exercises for brain health, but not to the point where it's taxing or causing irritation or frustration, because then they're going to be, quicker to not want to engage in those activities, and also that could really bring down their mood. A lot of our patients talk about how they feel that they've lost confidence in themselves and they're embarrassed because they're aware of the declines that they're experiencing in cognition. And so we want to also consider that as well. But I think, these compensatory strategies need to be implemented early on, even when the patient is not really having any difficulties, because then what you're doing is you're, sort of teaching this new routine, and it'll become a procedural memory. If you set up a memory station, where you put your keys, your glasses, where you walk in and maybe set up your mail if you run to the mailbox, things that you do that are routine really help, because then patients get used to that, and then it becomes a little bit easier to continue even when there are some cognitive declines.
That makes good sense. Our next question is probably good for Amanda. Mike in Iowa asks, why don't other people notice the changes in my spouse, the cognitive changes, the difficulties with conversations and day-to-day activities, and follow through on things that we discuss and we plan?
I think a lot of spouses and care partners can echo that frustration. Living with your loved one, you know that person so much more intimately than other people do. I mean, you're seeing the 24-hour span, the week-long span of little things here and there that are different from how they used to be. And so I think the fact that you're living with them makes a big difference. But if you look really closely at some of the interactions that other people are having with your loved one, you might start to be able to pick up on why exactly they're not seeing what you're seeing. So for example, if your loved one looks good or, looks a certain way or, seems to follow a conversation well enough or gives a very brief or vague answer or even like answers questions with a joke, some people might not pick up on that's a sign that something's different with them. And even just the lack of follow through that you're seeing, that person may not pick up on that with just a quick phone call or a short visit. They're just not seeing that whole span of events. So they're missing those things that you're seeing. So, I think it's hard to hear that people aren't seeing the same thing, but it's a good opportunity to connect with people that do understand, whether that's through a caregiver support group or like an online caregivers forum, but there are other people that will definitely understand what you're going through.
Okay, good. I hope that's helpful to people. Amanda, we have a couple more questions that I think are going to be in your category here. So Penny in Ontario is wondering, as cognitive issues continue to worsen, and the care partner is in the position of making decisions, how do you handle the fact that your loved one with Parkinson's may not accept those decisions you're making or comply with the decisions that are probably really best?
Sure. It's so challenging, Penny, because, I'm sure you're used to making decisions with your partner in a certain way, right, over your history together. Maybe you sat down, weighed the pros and cons, had a logical discussion about what the right decision was and why. But now, because of the cognitive changes, you're in this position where these decisions are maybe more one-sided, or your loved one doesn't understand the reasoning behind it. So I'd say in this situation, first rule of thumb for me at least is to pick your battles. So is there any flexibility with this decision that needs to be made? How harmful is it for your loved one to not comply or not adhere? If it's a medical decision, you would definitely want to consult with your loved one's doctor to see, okay, what would it mean if we didn't actually do this? Or what are the other options? I think too, in this situation, I would try to get a sense of, okay, is there anybody else that your loved one trusts, someone else that holds authority, who could step in to be the bad guy with this decision? So it might be the doctor that your partner trusts. It might be a good friend, or even like a religious or spiritual leader that they trust or look up to. But somebody else may be able to weigh in and validate this decision that needs to be made, and that might be enough for your loved one to kind of go along. But even too in the situation of partnering with your doctor on this, it's possible that the doctor could write an order for this decision to make it a little bit more formal, if it's not medication related already. But I think another possibility to consider here is presenting the decision at hand as a trial. Like, we're just going to try this out. Let's give it a couple of days. Let's try it for a week and see. Or let's give this a month and then we'll reassess. Sometimes having that out is enough to help your loved one feel less threatened by that decision.
There's so many things that caregivers might want help with but can't get help with. And when there's something that you can get help with, when you can get help from a physical therapist or an occupational therapist or a doctor or somebody else who has expertise in an area and can really deliver a message, it must be good to be able to offload some of the responsibility for something. And also your idea about sort of easing into it and giving somebody a way to sort of soften the blow of what you might need to deal with sounds very smart. Amanda, we have another question that I think is well suited to your skill set. Bill from Florida asks a really essential question, so poignant. How should I deal with the anger and the heartbreak of my spouse's cognitive problems?
Just really taking care of yourself. And this might mean a support group. It might mean individual counseling for yourself, even things like journaling or meditation or prayer, but really allowing yourself to see this as grief, to acknowledge that this is a loss. Even though your loved one is still living, you're bereaved of things not being like how they used to be with your loved one, with your relationship, with the things you used to be able to do together or enjoy, or how you used to be able to communicate with one another. So I think, taking care of you means also building in time to not be in the caregiver role, even if it's a short window of time, but taking those breaks to just be you can really be good for you. And I think part of this heartbreak that a lot of caregivers experience is that sometimes there are these moments of clarity that your loved one has, and then when the confusion resumes later that day or a little while later, I mean, that is just, it's like another wave of pain for you to see that. So I think really it's like a lot of little losses all day long. So again, I would say see this as grief and really try to prioritize finding supportive outlets for yourself.
That's good. Yeah, you really have to acknowledge how significant the changes are over time. Yeah. Amanda, one more question if we can. Sorry to keep peppering you with these, but Linda in Michigan, she asks about how do I respond to my partner's delusions, their persistent feelings that I'm stealing money or that I'm being unfaithful to them. How do I react to this? How can I cope with this?
Yeah, I'd say first step is to take a deep breath and keep centered in knowing that if he was well, he would not be accusing you of this, right? I mean, it's so painful to be accused of these things. So that deep breath, that moment of pause is for you to try to just briefly remember that he is not well. And when you can keep that in mind, you may be able to consider not exactly what he said, but what is the emotion that he has underneath what he said. In these situations, fear, hurt, of course, even though you didn't actually do those things. But you've probably experienced, okay, what if you responded by reasoning and logic, telling the real truth? Sometimes it really doesn't go well, because what you're doing in that situation then is invalidating what they see as reality. You're giving them information that's inconsistent with their version of reality. So, in these cases, again, try to acknowledge the emotion underneath what was said, and also, again, acknowledge that this is his reality. I say also, if you can, very calmly, try to ask some questions when he accuses you of this, to get a little bit of an impression. Why is he thinking that this happened? What is leading him to think that these things occurred? Because when you have a little bit of that detail, you may be able to then sort of steer the conversation in a different direction. So, in some cases, of course, your response may need to involve white lies. That can be really uncomfortable. I know it's really hard for some people to start incorporating that at points in time. But, it's important to remember that you being right in this situation and the real truth being known sometimes matters less than your loved one remaining calm and being reassured and having that validation, of what they're saying to you. That fear, that hurt, that the emotional piece is valid for them. So, I mean, it's really tricky. Yeah, it's really tricky. You want to try to figure out how to validate this distorted reality, but also then redirect them maybe into a different topic or direction if you can. That's something that's less stressful or problematic. It really is trial and error. I mean, that's a challenge So again, it's really trial and error, but it will involve communicating in a different way than you're used to communicating before the cognitive impairment started.
Mm-hmm. Amanda, is there anything that can be done to help with this? Any treatment, any interventions?
I think definitely it's worth talking to your loved one's doctor, absolutely, because sometimes there are medication adjustments, medications to remove, to add. So it's absolutely worth exploring and letting your loved one's doctor know what's going on.
Okay, terrific. Thank you, Amanda. Now I'm going to turn to Adriana. And Adriana, did you have something to add about what we were discussing with the hallucinations?
I think Amanda covered it, but I think that we should encourage loved ones to actually talk to their doctors about it, because, I think sometimes people say, well, if I tell my treating physician, then they might give medication that will turn my loved one into a zombie or make them very lethargic and non-responsive. And I want to assure folks that that's usually not the case. There are medications that can serve to decrease those delusions or the hallucinations, because as Amanda pointed out, just as much as it is, difficult for the patient, it's also difficult for the care provider and the people in the home. So it's very stressful for everybody. But I think that we should also consider having a discussion with our physicians about medication changes.
Terrific. Thank you. Adriana, I have another question for you. Gail from Florida sent us a question. She's wondering, at what point do I need to take over financial decision making and push to give up on driving and maybe even some community activities like volunteering, the things my husband's been involved in and enjoyed for his whole life?
Sure. So I think that it's important to understand the cognitive areas of strength and weakness. There are a lot of examples embedded in that question, so I'm going to try to break it down a little bit. I think driving is a very hot topic. It's very difficult because it takes away your independence. It's something that folks have been doing for a very long time. And so when that's, no longer available to them, then it causes a lot of hardships within the home. Sometimes adult children get involved to help. So it can be a very stressful situation. I would like for individuals to know that there are driving evaluations that are available. Those are usually done by physical therapists, occupational therapists, neuropsychologists. Folks can go in for a driving evaluation where they're actually taken on the road and assessed. Some of them have like a virtual reality setup where you can go into a clinic and try it that way. But what's important is that a lot of times, even if we see subtle cognitive changes, what we also see are changes in processing speed, right? That's mental processing speed or even physical sort of agility and movement. And so we need to consider that when we're talking about driving, that it can be a combination of those two changes, mental and physical. And while your loved one can be a wonderful driver still, with Parkinson's, they might not be able to react quickly enough if somebody on the road were to, present a hazard, or if something were to come to them and they would have to make a quick decision. So I think for driving, it's important to consider the driving evaluation. That also sometimes helps patients understand their, weaknesses in that area. And I think for financial decisions, I think there could be some safeguards that can be implemented. And as Amanda said, it's always nice to start with a trial. So let's give this a trial. And what are we talking about as far as finances are concerned? Are we referring to writing checks or managing a bank account? Or is this more about stock options and, investments? So I think that, it's always nice to have a team approach. Where maybe the patient and a loved one work together, and the loved one can sort of come from, behind and check the bank account and check to make sure that bills have been paid, and that things are transitioned slowly so that the patient doesn't feel, kind of an emotional hit as well as, things are being taken from them and they no longer feel useful and involved. So I think that, overall, when you're looking at abilities and tasks and how to maybe share that load, it would involve a trial, and it would involve taking a look at cognition and really assessing where the areas of strength and weakness are. It's also important for folks to know that you can be reassessed and go through neuropsychological follow-ups on a yearly basis, so that way they can take a look at your patient and how they've changed over time, and then that helps tailor, some of the decisions.
Oh, good. That's good to know. I wasn't sure whether neuropsychologists would follow up with people over time. So that's great that it can be a touchstone and an enduring relationship. Thank you for that. So it sounds like there's some things that may be something that you discontinue entirely, and then other things that a more graduated change will work for. So that's
right. When it comes to volunteering, I also think it's important to not just consider the actual, quote, job of the patient.
Mm-hmm.
Because it provides so many other things, right? It provides socialization. You're out of your home. You're engaging with others. It's rewarding. There are a lot of our patients with Parkinson's disease that do very rewarding activities. They read to young children at elementary schools, or they sing to patients in nursing homes. So I think that if you can gauge, the cognitive load of their volunteering activity, then you might also be able to step down that cognitive load and still allow them to engage, but maybe with something that's not stressful or difficult.
Great. All right. I have another question I'm going to ask Amanda to take on. Pamela in California sent us a question, and she's asking, how can I creatively and kindly be present when I'm interacting with my husband, and it's apparent that he needs more time to process things, both and react to them, whether it's physically or verbally. He just needs more time, and it's frustrating to me.
Of course. I mean, I think practically speaking, it's easier for us to be patient if we're not in a rush, right? So as much as possible, try to allot enough time to move through the task that's needed to be done. But I think it's important, of course, to try to remind yourself that they're not doing this on purpose, that the way that their brain is changing really requires them to have this extra time to move through the conversation or to complete the task. And I think, again, to stay kind to them, it really means staying kind to yourself as well. And so trying to be mindful of the needs that you have as the caregiver to take breaks, to build in short windows of time, even if it's not, a full respite opportunity, somebody coming in and assisting. Maybe it's even just putting on some music when you're completing, if you're waiting for your loved one to complete a task. So it's little things that can help you get through it and kind of make that transition through that time they need. But I want to say as well here that this is a great opportunity to try to delegate some things off your load to people that you trust, whether it's family, friends, people in your community. There's so many people that, that may know your situation, but, and would love to help somehow, but really just have no clue, what you need or how they could help. And so if you have a little time, it could be worthwhile making kind of a list of what you do during the week, what needs to be done, those tasks, and getting a sense, okay, what could be delegated from this list to somebody else. And more often than not, I think people would be glad to say, oh yeah, that's totally something I can do. So that's a consideration as well, just to kind of lighten your responsibilities if possible, so that then you can be maybe a little more present like you'd like to. And I want to add something interesting I learned from a wise person a couple of years ago on this topic, is that we need to consider how many Mississippis, right? So 1 Mississippi, 2 Mississippi, how many Mississippis does somebody with cognitive impairment need to process and respond? Okay, so consider that we're all playing a game of trivia. Some of us get to respond to that trivia question after 1 Mississippi. And there's a group of people that they can respond after 3 Mississippis. But this last group, they have to wait a full 5 Mississippis before they can answer that trivia question. It's going to be really frustrating, right? For the people who have to wait 5 Mississippis to answer, they're probably going to get, really frustrated, maybe even checked out and just stop playing entirely because they'll never have a chance to answer. So, in this situation here, try to gauge how many Mississippis does your loved one need to complete this task or to respond. So something to keep in mind.
That's great. That's really helpful. Thank you. It's tough. I'm glad that that this question kind of encompassed both thinking and speaking delays as well as movement, because I think it really does. Parkinson's can affect both. So the changes are noticeable in both areas. And we at the Parkinson's Foundation, we actually have one resource I wanted to call out here. It's a webinar on cognition. And I think it really gives very useful information to help people understand all of what goes into cognition and communication, and all of what goes into the difficulties that can occur. To just make people aware about it can really, really be helpful. Thank you so much, Amanda. Adriana, I have another question for you. We heard from Valeria in Puerto Rico, and she was wondering, in the advanced setting, is cognitive therapy helpful?
So this is a hard question because I don't want to discourage folks who might have the opportunity to do cognitive rehab. I think cognitive rehab has sort of mixed findings in the literature, but overall, the message is positive, that people can benefit from that. But I think for those that get the greater benefit, it's seen in the early stages of the disease, where you can still implement compensatory strategies and learn new tasks. And it also is helpful when there's a caregiver component. So when somebody is there with the patient to help. And it can be even sort of helpful for the caregiver, because some programs have, stress management or relaxation techniques for the caregivers to implement in the home. So it really does depend on the cognitive rehab program. There are several options for that. I would say if your patient is very impaired, then you might want to reconsider, because you don't want it to be stressful. So I think what you could do is you can ask the institution or the program providing this intervention to give your patient a trial run and see if they can manage the load. If it's something that can be of benefit to them, then I think it's a great idea. It'll keep people involved. It'll help them socialize. It might help them implement compensatory strategies in the home. So it depends on the program and what the program has to offer, because I think that still some things can be implemented in the home to make things a little bit easier, both for the patient and the caregiver. Some studies have looked at improvements in functional abilities and even mood, so looking at symptoms of depression, and those results are a little mixed as well. And then there are some studies looking at how long these benefits can last for. So, if you're looking at the literature, it's a little mixed, but I would suggest that you go with your loved one, give it a trial, see if it's a good fit. And then that way you know that you're not missing out on something that could be helpful for the patient and the caregiver.
Okay, excellent. Can you talk a little bit about cognitive rehab versus cognitive therapy, and also the sorts of professionals who would do this, and a little bit more, if possible, about what it might entail?
Sure. So cognitive behavioral therapy is usually done for individuals with mood difficulties. It's, shown to be very effective in combination with medication for things like mood disorders, so depression or anxiety. And we know that a large number of patients with Parkinson's disease suffer from these mood conditions. It can be a manualized treatment for some, but usually it entails homework. Where you're learning how to do new things, you are being held accountable for the homework. So if it's for, more of a mental health symptom, then you can get a marriage family therapist to do it if they've had the training for that, or a psychologist or psychiatrist that can also offer the service. It's important to ask if they're going to be offering you cognitive behavioral therapy or if it's a different type of counseling service. So that's, a good thing to know what you're signing up for. And then when we're looking at cognitive rehabilitation, those programs can vary. Some of them are manualized treatment, where individuals come on a weekly basis or so. There's also homework, but that focuses on cognitive skills. And so some of the things that it directly examines and then tries to improve on are things like executive functioning. So planning, organizing, sequencing, problem solving, which we know are some of the areas that decline with the progression of the disease. Also helping with attention, concentration, and working memory. And then trying to figure out how you can improve in those areas and then implement compensatory strategies to help in day-to-day functioning.
That's very helpful. And I'm so glad you mentioned some of the areas that are usual difficulties for people who are experiencing cognitive problems and dementia, frankly. That's fantastic to know all that and very hopeful too, I think. I did want to ask one more question, and it's sort of, I thought of it when you were speaking, Adriana. Somebody had also pitched a question. Janet from Illinois was wondering about changes to make in the house that might help make it a more relaxing and positive environment. Amanda, I don't know if you want to speak to that. Adriana, you might chip in on that as well if it suits you.
Sure.
Sure. I can start off if you'd like, Adriana. I think of when you consider a good environment for someone with cognitive impairment, you want to think of anything that can be misinterpreted as threatening in that space, and do consider all five senses. So, try to envision what your loved one may need before they need it. This means thinking of things like temperature. Is the temperature at home, is it enough? Is it making them comfortable enough to want to sleep at night? Is it the right temperature? Even thinking about how the temperature might impact, their being comfortable getting into the shower. I think too, when you are thinking about the environment, okay, think about what's on the television right now. Is it possible that your loved one might be confused or scared by what's on the television? I've heard somebody who actually thought that what was going on on the TV was actually happening in the room. That may not be your loved one, but it could be, so definitely think about things like that. I think too, the lighting is important. So in the environment, thinking about the lighting, how could it be improved to reduce shadows, especially as the day goes on? How could it be, tailored a little bit to try to reduce those shadows that can cause confusion, or people might see things from those shadows that aren't, really there. They're misinterpreting that visual stimuli, right? So I think also I want to just leave off for myself with this question, keeping in mind that we as the caregiver are part of the environment. What we bring forward is how we feel, our mood. And so if we need a break, we should take that break, right? I mean, we should try to find opportunities to make sure that we have the support we need as a caregiver so that we can try to influence the environment, as best as we can in a positive way, in a calming way.
I have a few cognitive suggestions. I think also making things a little bit simpler. I think one of the most common complaints is patients have a hard time working their remotes for their television set. And I think now with technology the way that it is, there are so many options, right? You can have a smart TV or you can have dual remotes, and it can be very confusing. So I think looking at your home and sort of stepping back and figuring out, what somebody could manage. We have very candid conversations with our caregivers, and sometimes without the patient in the room. And I know that these conversations also happen in support groups. I've heard it said before, and I'm hoping that it's not offensive, but individuals have said, think of, a young child, and if a young child had to manage everything in the home and you would want them to be able to do it successfully, what could you do to implement that structure? And so we tell patients and their caregivers, it's not, that we're being offensive, but we want to be able to make the patient feel that they can still manage their home. So bringing down the level of complexity for a microwave, for the remote control, for the alarm. A lot of the doors now don't require keys. They're keyless entry, but you have to remember your code and plug it in order to get into your front door. So things like that, kind of just stepping back and taking a look at your loved one and figuring out where they struggle in day to day. And if you can implement those changes, I think that, that would give them more independence to be able to manage things that they want to do for themselves. Amanda made a great point about the environment and being comfortable. Some things like removing carpets or busy patterns, because some of our patients have, sort of visual perceptual changes or hallucinations from their medication or the progression of the illness. And patients have said, I can't handle when the patterns on the carpet start to wiggle or move around. It causes me anxiety. So I think paying attention to our patient and figuring out what troubles them in day to day, and seeing how we can maybe do without that.
That's great. I think that's really helpful. Thank you to both of you. I think that's probably as far as we can go with questions. There were great ones. Is there anything more that either of you would like to add, Adriana or Amanda?
I think it's just a important thing to remember that we're here at the Parkinson's Foundation on the helpline to guide you to those local support groups. What's available near you as far as resources that may support you as the caregiver. We talked a lot about getting involved, maybe that online support forum. We do have that PD Conversations, our new online community, and there is a caregivers section there. So that's important to keep in mind as well, that we're here for you. You mentioned, Jill, those books that we have, the booklets that are really useful. So keep this in mind, definitely to the helpline.
Yeah, great.
Yes, I agree. And I think that looking at the Parkinson's Foundation literature, there's great benefit in that. We've talked about a digital toolkit that would be available after these webinars, and that information is in English and in Spanish. So encouraging folks to look at that material. And you might not need it now, but at least if you're familiar with that the references are there, then you'll be able to maybe recall that in a moment of stress when you're trying to find some answers to what is happening in your life. I think the one important thing is also to trust in your care providers and let them know what changes you're experiencing as a patient or what you're observing as a care provider. There are some changes that occur that are associated with either Parkinson's disease or the treatment of the condition that can include changes in behavior, in mood, that can result, in changes with sexuality, with binging on food or certain items, with gambling, sort of punding and doing things around the house that can either be an exacerbation of an individual's personality and current, or previous function from before the onset of their condition, or it can be something that happens that's out of character that takes the family by surprise. But there's important information on how to manage those symptoms with and without medication. So I just want to encourage folks to talk to their care providers and, make sure to report that. Some of that can be very personal and difficult to talk about, but there are resources available.
That's terrific. Great. Thank you so much. I hope that this is really valuable to people, and I hope that that people feel free to reach out to the Parkinson's Foundation and let us point you to these resources and encourage you to make these connections, because you're not alone. Although it sure feels like a lonely pursuit at times. We'd be delighted to help. So thanks for tuning in today.